Okay, we have our last speaker, Phil Eckhoff, will be speaking on the integration and interpretation of partially effective interventions on malaria transmission to inform best practices and policies for malaria control and elimination. And I think I just used one of your minutes in the...
All right, good morning. I would like to thank Diane Worth for the invitation to speak here and the 4 previous speakers for really providing a really good coverage of what are some of the key challenges in each different set of tools, whether it's in vector control, vaccines, drugs, surveillance.
Advance the slide.
All right. So one of the important things to keep in mind is that right now there's been a lot of good news recently. There's been a lot of progress. Malaria epidemiology has changed a lot over the last 15 years. The number of deaths has dropped. There's been a big scale up of new tools in terms of the long-lasting insecticide-treated nets, IRS, ACTs. There's been a big increase in financing. And there's been a really big change in the proportion of people living at different levels of endemicity, and the shift of what fraction of people are living in these really high levels of endemicity. There's been a real shift to the left. Right. At the same time, the African malaria landscape has shifted. A lot of the areas that in the year 2000 were incredibly high levels of prevalence have declined substantially over the past 15 years. Next slide, please. Within this set of gains, vector control has played a really major role. Previous slide, please. Vector control has played a major role in these gains of the last 15 years. In 2000, just about 2%, a bit under 2% of the population slept under an insecticide-treated net, and that was up to about half the population in 2015. And in Samir Bhatt's analysis that came out last year, ITNs and IRS were responsible for a large part of this decline. Next slide, and next slide, please. This was enabled by a huge increase in funding over that time interval. These interventions aren't free, they're not necessarily cheap, but this was a great scale up by the international community and by a lot of the countries themselves, and it had a big impact. Next slide, please. But in the context of all these gains, it's important to recognize that progress is really fragile. I mentioned that vector control was a major part of these gains, but we see the spread of, and now very broad spread and increase in prevalence of pyrethroid resistance. In addition, once you get out the bed nets or get out the spraying, it has to be done again. If you never just stay at a given level of coverage, you have to continue to work to maintain that level of coverage. Otherwise, over the next months to years, things get back to where they were before. In addition, there can be a real shift in vector species feeding behaviors. Just on the right here is the shift observed in the Solomon Islands, some data from Tanya Russell. And this could make indoor targeted interventions a lot less effective. And Knuckle Jitness from Swiss Tropical and Public Health Institute gave a great talk yesterday on how both physiological resistance and behavioral resistance can actually decrease the effect of vector control interventions. Drug resistance is another big issue. Rise of artemisinin resistance, piperacin resistance, and so on have the real challenge of rolling back some of the gains that have been due to drugs. In addition, there's also a whole set of other challenges about funding continuity, social order, what happens when there's a breakdown in civil society, breakdown in funding, breakdown in the ability of a health system to deliver interventions, natural disasters. All of the progress that has been achieved depends on the ability to continue to give out these interventions and for them to keep working. Next slide, please. So in the context of a lot of progress being made, but this progress being fragile, that's the context for the big goal of eradication. The ideal is that the burden of malaria would be at zero and stably robust to pesticide resistance, drug resistance, another financial crisis, economic crises, civil wars, fatigue in funding, and so on. And also robust to evolution of resistance. Because given numbers, given time, given pressure, evolution is going to win. Another big issue on motivating eradication is that, previous slide, please. Another big issue for eradication is that as progress is made, as the number of deaths drops to 250,000, 100,000, it's going to become even more concentrated in certain parts of the world. And saying any level of deaths is acceptable is going to result in an increasingly inequitable distribution of health burden. And eradication as a goal drives towards equity. But at the same point, it's an attractive goal, it's a big goal, it's also really difficult. There's huge heterogeneities in transmission intensity, vector species and their behavior, population densities, what are the housing, the level of health care, and also some areas where it's really difficult to actually do logistics and deliver interventions. And then also always dealing with the evolution of resistance. Next slide, please. In the context of this, there's a basic analytical framework for how do we think about eradication. We partition the world into different regional campaigns and then start to figure out what can be done in each one. Within each context and in the given transmission setting, figure out a way to reduce transmission, and there are a number of tools available for that. How do we clear infections? And there are a number of tools for that. And then prevent reintroduction. And we have a whole set of available tools, both now and tools that are going to be in the pipeline over the next 10 years. Novel vector control, there's been some fantastic talks this week about that. Some great new approaches on the pipeline for diagnostics and for drugs and vaccines. And then also want to actually just mention a couple things. One of the things that we need to make sure not to overlook is the ability to actually increase and make delivery easier. What is there innovation and ways to actually achieve better logistics? What is the product development strategies that actually make it easier to deliver those tools and actually get them to higher coverages? And what is the role for modeling and quantitative analysis in terms of figuring out how to put these together? So talking about modeling for a moment, next slide. There's a lot of really good work in terms of studying different tools and different combinations of tools in a variety of settings. So in terms of mass screen and treat, mass test and treat, MDA, combining that with vector control, there was some great work by the Imperial College Modeling Group here on the left, in terms of looking at in a variety of settings with different levels of transmission, different levels of seasonality. What do you get for different combinations of vector control and drug campaigns? In terms of looking at vaccines, Melissa Penny at Swiss Tropical and Public Health Institute led a 4-model comparison effort looking at what would the potential rollout of RTSS be in terms of reducing the burden of malaria. Next slide, please. Some of the work in our group has looked at how is the impact of vector control interventions affected by vector behavior. And this is basically as indoor feeding switches to outdoor feeding, or if the baseline of arabiensis is more outdoor feeding, it becomes a lot harder to win with indoor targeting vector control tools. Next slide, please. And then finally, Jillian Girardin has done a lot of work as far as putting together simulations of different locations with different levels of transmission intensity, different distributions of households, and looking at what different combinations of drug campaigns could be needed to actually achieve elimination in different local settings in Southern Africa. But the basic message of this one is that higher coverage and frequent rounds of delivery are actually important as far as using these tools. So we have tools and models to actually explore a lot of these tools and a lot of these interventions. But I want to take a step back from diving into the weeds on any of those and just focus on a couple key points. Next slide, please. So from all these studies, it's pretty clear that there's no single silver bullet that's going to succeed on its own in all settings. So that immediately drives to combinations of interventions. And that requires developing locally appropriate mixes that are tuned for that ecology, that set of transmission system, and that level of baseline intensity and the underlying health system. Driving up coverage of interventions is essential. One of the important things on this is the durability of interventions. There's a lot of interplay between durability and coverage. Because if you start out and you're achieving 85% coverage, and it takes a year to actually get that coverage up there, and the efficacy of the intervention is falling away rapidly over the course of that year, say for spraying, or a bed net that tears, then all of a sudden the average effectiveness and effective coverage that you achieve over that year is significantly lower than the 85% that you thought you were getting. Modeling and analysis can help to explore these combinations to look at finding mixes of interventions that can optimize over various criteria. What's the baseline transmission? How much will each intervention reduce transmission in that particular setting? What is the rate of reintroduction and baseline rate of case management in that area? What are the costs and the available logistics capacity? Next slide, please. Great. One of the concepts that gets talked about a lot is what is the basic reproductive number of the disease, as far as how far do you have to push down transmission until this is less than 1. But this isn't the whole job, because untreated malaria infections can actually last for several months or longer. And if you just get with a 6-month average infection duration and a controlled reproductive number of 0.9, which basically means if you have 100 malaria infections, those will be replaced by 90. So that's a very slow decline in the total infectious reservoir. And that means that years later, you still have a decent amount of infectious reservoir. Pushing down to 0.7 is better, but it still takes multiple years. And given that a lot of these interventions will have durabilities shorter than the time interval that they need to be effective, that actually goes into the planning as far as how many rounds, how often are you going to have to get back to that level of coverage. So it's not just enough to get the reproductive number less than 1. It has to be held there for long enough to actually reduce the infectious reservoir. But there are multiple ways to win. One is pushing it down much lower than 1. The other one would be to reduce the average duration of infection to where treating a very high fraction of infections. If you can get down to a week-long duration of infection, then even a reproductive number of 0.9 will actually go away fast. Next slide, please. Coming back to the effect of coverage and the efficacy of the intervention. This is basically looking at what is the maximum reproductive number that you can actually eliminate with a vaccine that has 80% efficacy and a perfect vaccine. Down here, if you're achieving 50% coverage, there actually isn't a huge amount of difference between those two curves, because it turns out that the residual transmission is not being driven predominantly by people who are vaccinated, but by people who are not vaccinated. So if you're achieving 50% coverage, the net impact of switching to a perfect vaccine is going to be significantly less than one might think. Whereas if you're achieving very high levels of coverage, say 90%, all of a sudden there is a huge difference between the 80% effective vaccine and the perfect vaccine. This often raises kind of a chicken and egg type question as far as, well, is it worth building a better vaccine if we're not achieving higher coverage? And this going from 50 to 70, 70 to 90, 90 to 95%, those are big, expensive changes in terms of increases in coverage. And if you don't have a great tool, it might not be worth spending on that. But the important thing is we probably need both. And what is the tool that actually makes it worthwhile driving up coverage? And what is the coverage that makes it worthwhile developing an even stronger tool? Because when you can combine the two of those together, you actually can disrupt very intense transmission. Final slide, please. All right. So in summary, the impact of an intervention and mixes of intervention depend on a lot more than just the initial efficacy. What is the achievable coverage? If a tool becomes easier to the exact same effectiveness, but it becomes a lot easier to deliver at high coverage, that's attractive. What is the duration of efficacy after distribution? How robust is the intervention to the evolution of resistance? These are all really important things to consider in terms of developing new tools. I also want to really advocate one of the biggest gaps is we need better innovations in logistics and delivery, and also in terms of linking the logistics and delivery to improve surveillance and situational awareness. And thank you very much. I would like to thank my colleagues at Institute for Disease Modeling, also Diane Worth and the Harvard School of Public Health, and our colleagues that we were working with and are working with in Zambia for the drug results that were presented earlier.